So welcome. Isn't this super exciting? I want to also thank RWJ and especially our organizers, Dorothy Daly, Michelle Frisco, and then Chris Backrack behind the scenes making all this happen. So here's what we have in store for you for this first session of this first meeting of the Interdisciplinary Association for Population Health Science. In a classic RWJ-inspired interdisciplinary approach, we're going to look at a problem from different angles, use the different lenses to increase understanding and imagine different things that we might do to address the issues that confront us. And since this is the first ever session of this new group, let me just take a moment to capture something that has been very prominent in my past interactions with many of the people in this group. And that is the spirit of the group. Its boldness to try new things like this, its capacity to respectfully challenge so as to improve our research, its focus on cooperativeness over petty competition, and then the solid relationships that emerge from a context like that. They become a resource for achieving our overarching goal. So let's keep that good spirit very much active as we go forward with this association. Let's make it part of who we are. Now, our panel conferred a bit, and we decided to reorder, to have Mark Hayward go first, to sort of set the stage with findings and explanations from a social determinants perspective, then have Laura Gottlieb about addressing social determinants in clinical settings, and finally Jeffrey Levy about the social determinants in the ACA and elsewhere in the big policy domain. And what we're going to do is each is going to speak for 20 minutes, and we're going to develop this kind of package of perspectives, and then we're going to discuss. So they'll each talk for 20 minutes, and then we'll have 30 minutes of discussion. And I'd like you to think in RWJ style about how these things relate and connect. They've done some of it, and so I'm really looking forward to it. And their bios are in the on the website online, so I'm not going to introduce each one, and probably they don't need an introduction. But we'll start with Mark Hayward, who's professor of sociology at the University of Texas, Austin. Thank you.
Thank you all for coming. It's an amazing event to be here at the inaugural kickoff meeting of Population Health. So many people in this room have worked so hard in actually bringing us here together on this day. So first things first, technological challenges here. The work I'm going to talk about today and the conceptual framing is really the product of lots of people. And lots of people in this room. But so now I'm going to get a little bit specific. If you were to think about health and how we approached health, I'd say 10, 20 years ago, we often were looking for relatively proximate risk factors, especially in the social sciences. But increasingly, people began to realize that the kinds of health outcomes that we were looking at really reflected very long exposures over the life course. And in some ways, they reflected combinations of exposures all the way back from prenatal environment and childhood into adolescence and into adulthood. Now, even today, in the kind of world in which many of us work in many disciplines, there's lots of ambiguity surrounding the nature of these relationships, the pathways by which these factors are operating on adult health. So I'm going to talk to you a little bit today about the ways that we ought to think conceptually how these factors come together. The other thing I want to talk about is that these issues, the kind of underlying conceptual frameworks, are really critical for thinking about public policies that shape population health. What's the timing of these policies, the age targeting of policies, long and short-term consequences, and indeed intended and unintended consequences of public policy. So the first thing I'm going to do is to talk to you about a developmental perspective on the life course and how factors over the life come together. Now, I'm not sure exactly how I pinpoint things, So I'm gonna see if I can speak into the mic and look sideways. So there are two basic phases of the life course that we want to talk about. One is the developmental phase. The other is the aging phase. And what I have done here is I've created 4 stylized curves, people A, B, C, and D. And in this case, we have some people that share these curves. So A and B share this first curve, and C and D share this the second curve. Now this is in childhood, and what you can see is already at birth, people that have advantages, there's already a difference in what we would call underlying capacity. And the reason I've drawn these curves, these are quite stylized curves, they summarize the underlying development and withering away, if you will, of a lot of biological systems that are underlying the health problems that we study, especially in adulthood. So if you notice, A and B, they strike off really fast, and they actually go pretty far up the, they're developing their capacity pretty far into the life course before capacity begins to change. Here we have the other two people. Their capacity is a lot less, and a lot of it has to do with the kinds of inputs that they have in their lives. Notice we have different ages, these dotted lines. I'm still having trouble here with my pointer here, with these dotted lines in terms of when they reach the peak capacity. And of course, there are certain kinds of turning points and different kinds of exposures that happen in adulthood that ultimately create an incredible diversity, if you will, about these lines. If you think about where these people are crossing these lines, it gives you an idea of heterogeneity in the population about when you're going to be losing capacity, and these different people are losing it at different ages. The real point of this graph is that out here, this level of diversity is really a product of this, it is a product of this, and it's a product of this. So that when you look at the adult population and the changes in underlying capacity for health, what you're really doing is looking at a combination of factors that emanate from in utero conditions, from childhood, from adolescence, and adulthood. And so the heterogeneity of population health and population experiences continues to grow throughout the life course. I'm going to get specific in terms of certain kinds of findings to give you a sense for what do we mean by this model here. And I'm going to look at a very simple conceptual framework here and give you some findings. One of the things we're going to focus on is the effects of child health and the effects of childhood SES resources, the things that are happening way back when. And we're going to be looking at the extent to which these kinds of early life factors potentially operate through educational attainment. And the reason you'll see in a minute why we choose educational attainment is we call it the master adult variable. But we're also quite interested in looking at the extent to which these kinds of distal factors may have a direct effect on adult health. Now, let me give you a sense from a disciplinary perspective. When dinosaurs roamed the earth about 15 years ago, and I might as well get specific here. When dinosaurs roamed the earth, the social scientists, when I was presenting some results I'll show you in a minute, they absolutely hated the idea that childhood health would have a long-term and direct consequence for, long-term and direct that wasn't mediated by some social set of exposures that happened in adolescence and adulthood. The idea is from a more social science perspective, these kinds of very distal effects would operate through more proximate conditions. So I'm just going to give you an example. This is a paper that some colleagues and I published a while back. And we were actually looking at the extent to which early life health, and it was a pretty crude measure about different kinds of health, but we were actually able to look at health in terms of its infectious disease component, its non-infectious disease component, and its autoimmune conditions. And we were looking at the association between these kinds of early life health experiences and different kinds of chronic morbidity in the older population. Now, you'll notice that these arrows point to significant effects. that the rates of cancer, the odds of reporting cancer, increased about 2.5, almost 3, for these different kinds of conditions here. We certainly found the cardiovascular effect. We found the chronic lung disease effect, and we found autoimmune conditions effect. Now, I'm not going to get into specific issues, but I can tell you when I gave this talk at the University of Wisconsin in about 2000 and 2001, every sociologist in the room said, well, you're not controlling for all the adult factors that would give rise to these kinds of early life associations with adult health. And I said, okay, you see these odds ratios right here? I said, and they said, well, yes. I said, well, here's the zero order effects. Actually, they were these odds ratios. I said, now do you want to see what happens to those odds ratios when I control for sex, race, age, parental death, childhood living arrangements, parental occupation, parental education, height, respondents' education, and respondents' wealth? They said, oh yeah, that should go away. I said, no, they're the same odds, right? They're exactly the same odds. They said, no, you've missed something. I said, well, what have I missed that's not part of this basket of goodies, right? And it's the first time in a kind of population level data set that we were beginning to look at these kinds of relationships. I will tell you, I had never really anticipated that the anti-vaxxers would come after me with a pickaxe, because here we have some issues about infectious disease. I hadn't even mentioned vaccines in this article, but somehow their media net is much wider than my thinking. So it's the first time I really ran into that group. Now let me give you another sense, because this is actually a gendered issue, because we have much stronger effects of actually the risk of diabetes with poor childhood health among women, but not among men for whatever reason, right? It's a quite gendered experience, and so paying attention to gender is quite important here. Now, you'll notice I've done the same kind of thing. Here's the risk of diabetes associated with poor childhood health in women 50 years of age or older in the population. Here's the adjustments for age and race. Here's the adjustments for, we add education, childhood socioeconomic status, and parental education. Do you notice any change in the odds? Anything there? Here's now we are actually adding in the adult body mass index, a factor that's really related, to diabetes risk. No change in the odds. And we finally throw in family income and wealth, and we've pretty well done the kitchen sink here in terms of everything we can throw out. And if you notice any major changes in the odds of diabetes risk across this, no, not a whit. So we want to go back to that original diagram. Do we have a strong effect? Yes, of early life conditions. In this case, when we look at early life health, we have a lot of evidence growing, and many people in this room have contributed to this literature about these kinds of direct and very distal effects on later life adult conditions. So let me come back to how do these kinds of childhood conditions actually combine with adult conditions here, and looking at educational attainment. So we're going to introduce this idea of their master variable, and you think about educational attainment, it basically allows us to run on all cylinders. We have better jobs, we have more discretion, we have better cognition, we have better everything, we have better social networks, we have better information, we're more proactive. You name it, we have it for those people that are better educated. And it is related to a host of downstream processes in terms of adult conditions. So some work I did with Jennifer Montez, who's a Robert Wood Johnson Health and Society scholar. She and I were looking at how does early life combine with education to affect people's healthy life expectancy. So I'm just summarizing these effects here. Adults who experienced adverse conditions were much more likely to experience unfavorable health events. The other thing is that childhood socioeconomic status and health quite are independently predicted different health events in the kind of work that we were doing. And last but not least, what is also quite fascinating is that childhood socioeconomic status actually showed a quite strong dose-response relationship. So if I go back to this idea the more disadvantage you have, the greater of the risk you have from the onset of ADL problems from functional limitations. I've just given you one example here. But there's a very strong linear dose-response relationship. The more nasty and pernicious your social environment is, the more you fall into negative health consequences. So how do adult factors come into play in this? Now, this is the other part. Childhood socioeconomic status only partly operated through educational attainment. Again, the sociologists generally like us to explain everything about early life as working through adult conditions, and it just is not playing out that way. But if you remember that little conceptual model that I threw up on the board about the inputs into capacity over the life course, you would begin to think from a more biologically informed perspective that these social factors actually get embedded in the body in ways that are going to have long-term consequences for people. The other thing is that childhood health influence is also not a function of a person's educational attainment. And if you think about all the kinds of exposures and experiences, those simple little boxes that I had in the model, all of these boxes combined in a quite additive and cumulative way to influence what we would call active life expectancy, which is the years of life that you live in good or bad health. So I've given you summarized the results here, and we're only going to look at people right now who have reported good or better child health. The results, by the way, are very similar for males and females, except the height of the bars is different. Now notice here on this axis, this is the childhood socioeconomic adversities. And at age 50, someone that has less than high school, okay, and has no adversities is expected to live in good health 7.7 years, and with more adversities in that same level of education, less than high school, they go from about 7.7 down to 6.0 years. So that gives you an idea about how the kind of adversities from childhood are coming through in this framework. Now notice also, though, if you have no childhood adversities and you move up the educational ladder from less than high school to college degree or more, you're jumping in an enormous way from 7.7 years of healthy life expectancy to 15.3 years of healthy life expectancy. This gradient is enormous in terms of education, and I will just point out the real bump here is college. It's really a phenomenal bump. The last thing I want to do is point out, if you were thinking about combinations of things, people that have zero SES adversities in life are very similar to people over here who have a lot of adversity, but you know, they go to college, or at least they have some college. So in this case, education is actually compensating for, if they can actually have a turning point in their lives, education is actually compensating. And lest you think that there aren't people in all of these boxes where all of those bars are, yes, there are people distributed across all of these cells that we see in the bars in the graphs. This is not just hypothetical. The last thing I want to point out with this graph is the enormous gap that we have in terms of healthy life expectancy in this population. Here we have people like no adversities in childhood and college education, and they go in that way from 7.7 to 15.3. Now, if you wondered why I was so adamant about my son who had no socioeconomic adversities, first, it was a sequential decision-making process in our household. Oh, please, God, graduate from high school. He did. So I knew he bumped up from 7.7 to 9.5. Then he was in college, and it was a little iffy about what was going to happen in college. I kid you not. We were on the 5.5-year plan at some point. So he got a 9.4, and I was still sweating bullets. But finally, I got him across the hurdle, and I moved my son up to 15.3 years of healthy life expectancy. And I was a very happy dad because I had done something that I thought was quite important. On the other hand, there are really people out here with lots of childhood SES adversities, poor people who don't go on and achieve a lot of education. look at this. We have over 9 years of healthy life expectancy at age 50, right? A huge portion of remaining life that separates the haves and the have-nots in our population. So let me just kind of summarize, and I'm going to go to the next slide. With adverse childhood contexts, we have shorter total life expectancy and active life expectancy. But I also want to point out something that's very important. Here's total life expectancy. Here's total life expectancy for everyone that has all the good things in life, 30.1 years. Here's total life expectancy for everyone that has all the bad things in life, 26.7 years. But notice the difference here in terms of the active life expectancy. The years of life spent in good or bad health is much more sensitive than actually mortality. So for us, it pays attention to begin to think about a portfolio or integrate measures of health and mortality, because sometimes when we look at things like mortality, or only health, or only mortality, or only one disease, we're getting only part of the picture that we need to have for a more comprehensive view of population health. So let me think about what childhood policy and how we think about upstream factors as health policy. So one of the things to note is that when we operate on children in terms of our policies, childhood conditions matter, even net of adult conditions. So think about policy. That's not, ultimately, we're investing in children, that's going to pay dividends. The other part is that in this world that we live in now, and I won't say in the past, and I'm not sure about the future, that when we raise levels of education, we're really adding to the stock of population health in our population. The other point is that when we're going to develop policies, remember, conceptual frameworks and empirical evidence point to the importance of policies and interventions throughout the entire life course. And last but not least, I know that we don't always intend to have health policies, especially when we think about education, but we should be beginning to think about in health and all policies the intended and unintended policies that better the human condition, that ultimately improve our health. So let me leave with this idea, health in all policies. That's from the Public Health Association, but I'm going to add a little caveat, at all ages. And thank you very much.